Hi guys, welcome to Podcast Met. The topic of discussion in this video is about the obstetric case history taking, where it has the following components in it, which are demographic details of the patient, history of presenting complaints, menstrual history, previous obstetric history, medical history, treatment history, surgical history, family history, social history, personal history, family planning or contraceptive history, nutritional history, and gynecological history. So, coming to the demographic details of the patient, we have name, age, residence, occupation. We also have to take the husband's name here. Um, Coming to the importance of each component of this name, as usual, as all of us know, it is useful for identification. And the importance of age in this is there are few age wise pregnancy complications which are in teenage primees. The first pregnancy of a female happens in very early ages, is called teenage primary. So in those people, the most common complications are anemia, preterm deliveries, abortions, psychological imbalance, fetal growth retardation in the womb, that is intrauterine growth retardation, low birth weight, etc. And maternal complications here are cephalopelvic disproportionation, placenta previa, failure of lactation. All of these can be maternal complications. And like in teenage primaries, there are few complications relating to the older primaries. Older primaries, in case the females who are getting pregnant after the age of 35 years. So in them, the most common complications are cephalopelvic disproportionation, preeclampsia is hypertension in pregnancy, where the blood pressure levels are more than 140 by 90 mmHg. And the next complication is eclampsia. Eclampsia is hypertension along with seizures or convulsions. Then gestational diabetes or avert diabetes, and the next complication is prolonged labor. This is due to the uterine inertia, and it is all the abruptio placenta, incoordinate uterine axis, failure of lactation are also common in these people as well. Then coming to the residents, normally as usual, region related diseases might prevail in the mother or the fetus. Then coming to the occupation, in low economic state families, low economic status families, preterm deliveries, anemia, premature rupture of membranes, and rheumatic heart disease, lactational failure due to anemia and stress are more common. This is because mostly of the nutritional deficiencies that we can imagine. And in high economic status families, there is more chances of prolonged labor, diabetes, obesity, fetus obese and macrosomy can happen, cephalopelvic disproportionation. And in farmers particularly, there are more chances of hookworm infections, which can lead to iron deficiency and which can lead to anemia in turn. So that is importance of occupation. Now coming to the menstrual history, uh, now coming to the history of presenting complaints, the females that come to the OPD of obstetrics will mostly test their UPT test. You know, all of us know that urinary pregnancy tests that females do to check pregnancy. It is like a kit. So with that, they will directly come mostly, but few people, the main complaints that they come with are amenorrhea. Amenorrhea is absence of menstruation since a long time, like 3 to 3 months, like that. So that is one of the most common complaint that the patient or the mother comes with. And the next most common thing that they come with is vomitings or any other things, morning sickness, etc. Now let me say the trimester wise complaints. Before saying the trimester wise complaints, let me say what are the three trimesters and what is the time period under which it is divided into. So first trimester is 1 to 13 weeks of pregnancy, and the second trimester is 14 to 28 weeks of pregnancy, and third trimester is more than 28 weeks of pregnancy, that is 28 to 40 approximately, 38 or 40 approximately. So this is the trimester, these are the three trimesters. Okay, then coming back to the topic, in history of presenting complaints, mostly they will come with amenorrhea. Then coming to the trimester wise complaints, in first trimester the female will mostly present with amenorrhea, vomiting in case of morning sickness, it is mostly called morning sickness, and also firm breasts which have Montgomery tubercles dark areola. They won't say this Montgomery tubercles or dark areola, but they will complain of firm breasts, bleeding. There can be bleeding, implantation bleeding it is called, when the fetus or the embryo gets implanted in the uterus. It causes bleeding, it is a physiological bleeding, and it can be pathological as well, like in case of antepartum hemorrhage. Then coming to the urination, there is increased frequency of urination, and there can be other complaints of fever with rash in case of any infections. Then there can be some vaginitis, like inflammatory conditions in the vagina, kind of other normal things. These are the things that I said before, or physiological symptoms. So let me repeat the symptoms again. In the first trimester, which are amenorrhea, vomiting, increased urination. One more thing that I forgot to mention here is weight gain. Weight gain will not be very significant in the first trimester, but in the next coming trimesters, it will be the most significant symptom that we should ask for. And the next thing is amenorrhea, vomiting, weight gain, increased frequency of urination, firm breasts or breast discomfort. It is called mastodenia. Then bleeding, that is implantation bleeding mostly, or it can be due to abortion or any other complication. Back pain will also be not that much prominent in the first trimester, but these all are mostly present in second and third trimesters. Then coming to the complaints in the second trimester, the most important thing that one should ask for is quickening. Quickening is the first experience of fetal movements by the mother. So if those movements, if she is experiencing or not, you should ask for it. Then about that quickening, the exact time period where the mother can feel the quickening is mostly between 8th to 20th week if the mother is a preemie, that is that if her pregnancy is the first pregnancy now, and if he is a multi-para, if she is a multi-para, then the quickening might be felt a little earlier, that is 16th to 18th weeks. And the other complaints are mostly similar to the first trimester, and weight gain and back pain will be more what is that called, more significant in the second trimester. There can be bleeding as well. Now coming to the third trimester, in third trimester as well, urination frequency will increase, and all the other or the same complaints as in the first and second trimesters. One more thing that we should ask here for is, we should know here is, first trimester there is increased urination. This is due to irritation of urinary bladder in the first trimester, but in the third trimester the increased frequency of urination is due to the pressure of increased size of the uterus over the urinary bladder. So these are the complaints that we take from the mother who has come to the clinic. Then we'll ask for her menstrual history. Coming to her menstrual history, you'll be asking about her last menstrual period. About her last menstrual period is very important in case of uh, so important in case of obstetric history taking is because with the last menstrual period you can calculate expected delivery date using Negler's formula, where the Negler's formula is the Negler's formula is the expected delivery date is equal to last menstrual period plus 9 months plus 7 days. And what if if she is having irregular menstruation, like long cycles or smaller cycles? If she is having irregular cycles, then the same formula can be modified as expected delivery date EDD equal to last menstrual period plus 9 months plus 7 days plus or minus 35 minus 28. For example, if her number of days in her cycle minus 28. 28 is the normal time period of a menstrual cycle. So her cycle minus 28. If her cycle is shorter than the normal menstrual cycle, then 28 minus her days. I don't know if you understood or not, but once check it in the Google or the textbook mainly if you want to learn it more easily. Then one more thing that I have failed or I have forgot to mention in the symptoms of first trimester is hyperemesis gravidarum, where hyperemesis gravidarum is the increased vomiting in the first pregnancy, mainly in the first pregnancies. It can be due to presence of female fetus, they say, family histories, ectopic pregnancies, young older primaries में ये काफ़ी common होती है. The complications, it can lead to complications like ketoacidosis, hypochloremia, hypokalemia, acute renal failure, esophageal tears, vitamin B1 and B6 deficiency, etc. If the in this hyperemesis gravidarum, there is a severe vomiting, severe increased frequency of vomitings. So you'll just treat her with IV fluids and vitamin supplements. If we want, we can keep her on antiemetics, ondansetrons mainly, which are safe during pregnancy, and we can even administer hydrocortisone to her. Mostly the IV fluid that we use is ringer lactate, as we all know. Okay, then coming to the menstrual history back, so we have learned about the menstrual period and Negler's formula. The next thing that you should ask in case of menstrual history is about her previous cycles, if they are regular or irregular, and the length of her cycle, length of the menstrual cycle, and if there are any pain, dysmenorrhea during the menstrual period. And about the bleeding, you have to ask for the bleeding, it is normal or heavy or moderate. You can check it by, they cannot say if it is moderate, heavy, normal. You should ask her how many sanitary pads that you use per day and how much bleeding it will have. So like that you will come to know the menstrual history, and should ask for any menstrual abnormalities in the past as well. If there are any clots in the menstrual blood, etc. That is about the menstrual history. Then coming to the previous obstetric history, here we are going to ask for GPALD analysis. What is GPALD analysis is, most of the people call it by different names like GPALD scale, GPLA scale, GPAL scale. like that. So where it simply means gravida, para, abortions, live, live, dead. Let me explain each. For now, we'll just imagine it is GPLA scale, okay, where gravida. Okay, it is a formula basically. Gravida means total past pregnancies plus present pregnancy. Total, all the pregnancies till now is called gravida. Okay, gravida. If the female have for example, let's take if a female have two pregnancies in the past, and she's carrying the third pregnancy now, then gravida G is 3, totally 3. Okay, then para is total past pregnancies, excluding present pregnancy, and aborted pregnancies are not considered, and the pregnancies should have crossed the viability period. In India, it is 28 weeks. Okay, this is para. If the okay, let's say an example again here. If the female was pregnant, same like two pregnancies in the past, one she has gotten aborted before the viability period of viability at like 13 weeks or 14 weeks, and now she's carrying a pregnancy. So what will be the para now? Para will be 1, because aborted pregnancies are not considered if the abortion is if the baby didn't cross the period of viability, like before 28 weeks, it is up, then it is called aborted pregnancy, right? So like that. Then present pregnancy is not counted, excluding present pregnancy, right? So like that, para. Then abortions, number of abortions, aborted pregnancies, uh, GPLAL is live. How many children till now are living right now? Who are living right now? So like that, abortions, gravida, para, live, and abortions. GPLA. Under this GP. Okay, let me say, if the female was pregnant 2 times in the past, and now she's pregnant, came to the OPD. One of her pregnancy was aborted before the period of viability. Okay, now calculate GPLA scale. Okay, GPLA score or scale, whatever it is. It will be, what can it be? Pause the video and video or podcast and think about it. Gravida. G is total pregnancies plus present pregnancy, where total pregnancies in the past are 2. Okay, 2 plus present pregnancy is 1, totally 3. So G3. It is G3 then. And para. Para doesn't include abortions before the period of viability, so that was minused, and doesn't include the present pregnancy, so that was also minused. So 3 minus 2, it is 1. G3 P1 live. One child was live now, one child is in the womb. One child was live, so living normally. So L1 abortions, one abortion has happened. So 1, that too. G3 P1 L1 A1. That is the GPLA score of the female. That is about the GPLA score. Based on this, based on the pregnancies and age of the female, we also decide her parity. In case if she is nullipara or primipara, multipara, grand multipara, elderly primigravida. Okay, there's so many things like multigravida, primigravida, nulligravida, like that. So many things, so many definitions are there. And nullipara means there are no previous pregnancies. Now she is pregnant, but there are no previous pregnancies. Okay, primipara means she's Okay, sorry. Nalli. That's right. Primipara is there is one previous pregnancy and now she is pregnant again. Multipara is more than one pregnancies previously and she is pregnant now again. Grand multipara is more than two pregnancies previously. Now she is pregnant again. Elderly primigravida means more than 35 years age. She is of more than 35 years of age and is pregnant now. Mm, all of these pregnancies should have crossed the period of viability. That is the important thing here. Then, who is a parturient? Parturient is person undergoing labor. Also remember this definition as well. Now, going to the next thing in obstetric history, it is previous pregnancy details. These are also very important. You have to take all the details about the previous pregnancy, like how many children and children did she had, and their gender. If there are any complications during the birth, if there what are the birth weights of the children that she had, if there is any retained placenta, early or late birth, pre or postpartum deliveries to be exact, postpartum hemorrhage if there is any, stillbirths if there are any, abnormal presentations if there are any, if the labor is if the delivery is normal delivery or C-section C-section assisted. So like this, we have to ask all of these things. And the next thing in obstetric history is history of complications. If there are any perinatal deaths, means perinatal means antenatal, intranatal or postnatal period. Antenatal is during the 9 months. Uh, then intranatal means during the period of delivery, the peaks of delivery like that. And postnatal is after the delivery. So all of these three phases may उसको if there are any deaths of the baby, you have to ask. Then other complications like preeclampsia or eclampsia, miscarriages, ectopic pregnancies, diabetes, pregnancy associated diabetes, gestational diabetes, etc. Anemia is the most common thing that is very prevalent in India, and it is the most common thing that is causing complications. So like this, we are done with obstetric history here. Then we'll go with the medical history. Medical history here includes previous history of diabetes mellitus, hypertension, epilepsy, asthma, tuberculosis, psychiatric disorders, thyroid disorders, etc., which are of like normal other medicine department ka history taking. It's like that only. And we should also ask for history of previous hospital admissions and why did she got admitted there, if there are any history of blood transmission, and if she is like that is about the medical history. Then going with the treatment history. In treatment history, we should ask for any allergy to, if she has any allergy to drugs, any long-term medication she's on, like anti-diabetes mellitus medications, hypertension, epilepsy, tuberculosis, etc. Then we should ask for history of immunization. If she has taken the TTs, like the females will also come for normal antenatal checkups, ANC visits to the hospital. We have to ask them there for TTs, so tetanus toxoid. Usually 2 doses are given during the second trimester, with 2 weeks apart. So we should also ask for that. And also the history of immunization means the immunization history of the female, if she had got vaccinated with all the things or not. That is also important here. And if she's on any medications like blood thinning agents especially, we should ask for it, because few medications are toxic during the pregnancy, which will cross the placenta and affect fetus, uh, which can lead to abortions or fetal growth retardation inside the womb, that is IUGR, or any other complications during the delivery or after birth. So, to avoid those, we should stop the long term medications which are harmful, which are teratogenic, especially. Then, coming to the surgical history, we are going to ask for any previous surgeries that she has underwent, like heart valve replacement, C sections, myomectomy, cone biopsy of cervix, etc. Now coming to the family history, in family history we'll ask generally about diabetes mellitus, bleeding disorders, hypertension, mental retardation, any other genetic defects, and also we should ask for consanguinity in their family. This is also important, as this will decide the genetics. This will have a importance regarding genetics. Then coming to the socio-economic history, we should calculate the family's score in BG Prasad scale or modified Kuppuswamy scale. We should decide the class under which the family comes, because TB, malnutrition, and IUGR are more common in poor housing, overcrowding, and lower economic status families. Like I've said, in the occupation under the occupation in this video or podcast in the start. So after socio-economic history, we are going to ask her for the personal history. Personal history is general, like if she has any habit of smoking tobacco, alcohol, any addiction to any other drug abuses, etc. Because those things might lead to IUGR and congenital malformations again. So after that, we'll ask for family planning or contraceptive history. We should ask what methods of contraception are used, if they have used or not, if there are any contraception failures that have occurred, and if there are any postpartum sterilization means after pregnancy, if she have got sterilized or not. Family planning, tubectomy, if she have undergone or not. And nutrition history is must and should, in case of maintaining the body weight, especially in pregnant women. They will be gaining so much of weight, and in India the malnutrition, anemia are more common in females during the pregnancy, and it is going to retard the growth and development of the baby from the womb itself. So that is very important. We should clearly take the nutritional history from the mother, and suggest her a proper nutritional diet plan which will support her and baby's growth and health as well. So after nutritional history, we'll ask for gynecological history. Gynecological history in case like general this about uh, abnormalities with the female ovaries or any vaginitis, all the gynecological disorders or diseases, if she had any in the past or has a family history of those diseases or not, etc. So with this, we are done with the history taking in case of obstetric cases. This is it for this podcast or video.